And thank you so much for coming here to hear my presentation today. And thank you for all of you who are there on Zoom. I appreciate you being here. What I want to talk about today is a little bit about my career and how I got to where I am, and some thoughts about this position and what I would do, or what I think anybody or somebody in this role might want to do for the School of Public Health. And I should be able to advance slides. That's not the case. I can't advance the slides. I try. Okay. Maybe this way. Okay, so I'm going to talk a little bit about me, some leadership highlights, some career highlights, my interest in this position, my vision for this position, and potential approaches, and then why me? Hey, I like to show pictures, especially of how I looked when I was young. So I am from a country in Eastern Europe called Romania. It's shown here, western side of it, Transylvania, where I was born and trained as an MD and then a PhD. I completed a residency in internal medicine, followed by a fellowship in diabetes, nutrition, and metabolic diseases, and then a PhD in clinical sciences. And while my work there was mostly clinical, it was clinical academia. I also did a lot of teaching and some research. And one of my most important research contributions while I was there was to establish a registry of pediatric type 1 diabetes in Romania. But then I had the opportunity to, and I was in academic medicine as an assistant professor for actually 7 years in Romania. But then I got an opportunity to come to the United States, my first trip to the United States, and do a fellowship with an NIDDK branch located in Phoenix, Arizona, the Phoenix Epidemiology and Field Studies branch of NIDDK in the late 1990s. And that was a transformative experience for me. And I'm going to talk a little bit about that. But at the end of that period, after a brief return to my homeland to convince my family to move with me, I got a position as a junior faculty at the University of Colorado. Yeah, as assistant professor in the Department of Preventive Medicine and Biometrics, which used to be in the medical school at the time. And so I went back to being assistant professor for another 5 years. And then I went up through the ranks, becoming associate professor and then professor and distinguished professor from 2021 and director of the Lead Center from 2015. Still doesn't go this way. A little bit about leadership highlights. Just briefly, I've been in national leadership of large multi-center studies, such as the SEARCH study. I served as chairperson of the steering committee for 15 of the 20 years that the study was funded. In DPPOS, I serve on the executive committee. I served on the executive committee for ECHO and KAYA. I also served as director of graduate programs in epidemiology, initially PhD and MS when we were still a department in the School of Medicine. And then when we started as a school, I was one of the first MPH concentration directors and worked to harmonize coursework and competencies across participating institutions and all that. I also served as the first Associate Dean for Faculty Affairs at the Colorado School of Public Health, developing what is called now DAPCO, or we just had one DAPCO in the old days, and then decentralizing DAPCO into department-specific appointment and promotions committee, developing the first faculty handbook, and setting in motion the promotion and tenure process at the school. Some leadership highlights in terms of leading strategic planning efforts at the Colorado School of Public Health. First time as leader of the research area under Dean Goff, and then the second time co-chairing the entire strategic planning committee with Dean Samet. I also worked with the Child Health Research Enterprise, and I was part of that strategic planning effort here on campus, and a few others. And then the development of the LEAD Center, a new center here on this campus. But I want to go back and talk a little bit about some career-defining highlights for me as an individual that contributed to my formation. And I want to highlight this postdoctoral fellowship that I had with the NIDDK in Phoenix, Arizona, which opened so many opportunities for me. First of all, the opportunity to work in the United States. Second of all, learning how to work with an indigenous community in that state, in that part of the country, the Pima Indian community, which is south of Phoenix in the Sacaton Reservation. And then also learning how to conduct field epidemiological research. The pictures you're seeing here, the one on the left, is me in front of the building that housed most of these landmark research studies. And I thought over the years that what I've developed here on this campus, especially when we were in building 402, looks so much like the space, the building, the areas that I grew up with there. A small building with faculty offices, some shared, some individual, and rooms where you do clinical research and see participants. On the right side is one of the hospitals on the Pima Indian Reservation there, and that's my husband with me there. But I conducted in-person visits on research participants in the diabetes prevention program study, which now I lead. So all beginnings have a thread. Anyway, this experience was transformative for me, as I said. One of the papers that I published is a landmark paper, Michelle referred to it, in the field of youth onset type 2 diabetes, showing in this population, over a short period of time of only 30 years, a doubling of type 2 diabetes in youth in this population. Type 2 diabetes used to be called adult onset diabetes. It did not exist in children. And we documented for the first time a rising incidence of type 2 diabetes in indigenous populations. And now we're seeing that in all racial ethnic groups throughout the world. Not only did we document this, but we also showed here that one of the strongest single risk factors for youth onset type 2 diabetes was exposure to maternal diabetes during pregnancy. In this population, an odds ratio of 10, which is a very strong odds ratio, very unlikely to be due to confounding. So here you see that among those children who develop type 2 diabetes as children or adolescents, most of them, if not all, have been exposed to maternal diabetes during pregnancy. And these effects are not completely due to genetics, but there are specific intrauterine effects that we still are learning about. And so with the team of investigators that I was working there, we were able to define this transgenerational vicious cycle by which obesity and diabetes during pregnancy begets obesity and diabetes during the next generation, and what we might need to do to break it. So given this transformative experience, I decided to, as I said, come back to the United States, and I joined in 2001, the University of Colorado Health Sciences campus. And for those of us who were here at the time, you remember this location on 8th and Colorado. And I remember my first few months and maybe a year kind of wandering around the area and the parks and the hospitals around, thinking, what am I going to do here? It's that beginning that is difficult, and I remember that. But I did join this campus and the school, and I started to define my research interests. And this didn't happen again in a year. It happened over 20 years. But I'm continuing to be interested in diabetes in youth, whether type 1 or type 2, burden and trends, surveillance, clinical evolution, clinical research, processes of care, development of complications. This area of focus led me into more work into what we call today developmental overnutrition or developmental origins of obesity and diabetes, to really study better the transgenerational transmission of diabetes. And there's a new society that is called Developmental Origins of Health and Disease, both in the United States and worldwide, ways involving both of them, because this is not specific to diabetes. It's actually applicable to health and disease more broadly. And then this led into life course epidemiology of obesity and diabetes, which goes beyond developmental origins because it goes across the entire life course. And certainly that has implication and leads to work in the areas of prevention of obesity, diabetes, and related conditions across the life course research. Which then brings me to talking a little bit about life course research and why I think this is an important, interesting, novel, integrative theme, and why I'm interested in it. So this is adapted from something developed by the Institute of Medicine with respect to obesity, but I've made it broader than that, because it's not only applicable to obesity or to diabetes or to their complications. It's applicable to cancer, to cardiovascular disease, to chronic diseases in general. And it has the opportunity to also link infectious diseases to chronic diseases. So what I like about this is that it not only considers the longitudinal life course transitions, what you see here on the horizontal axis, from preconception to infancy, early childhood, adulthood, and takes into account sensitive periods of development and accumulations of risks over the life course. But it also has the opportunity of integrating what we call multi-level environmental factors, which could be detrimental or could be positive, contributing to positive outcomes. Because everything that happens to individuals is the result of this multi-level environment. Below the skin, genetics, epigenetics, for example. So above the skin, nutrition, physical activity, the built environment, social support, access to care, disparities, structural factors. So the multi-level environment is an essential component of the multidimensional framework used by life course research. And these factors all contribute to health and disease. Which is why another career-defining moment for me was when I had the opportunity to start the LEAD Center in 2015. And it was based on frameworks such as the one I showed you, that I convinced stakeholders here on campus to support this initiative, which was very novel at the time. Nowadays, you might think everybody is doing life course research, but at the time it was novel. So the initial partners who decided to invest and support this were, of course, the Colorado School of Public Health, but also Department of Pediatrics in the School of Medicine. For a lot of reasons, this is very interesting and important to pediatrics. Children's Hospital of Colorado, the Anschutz Health and Wellness Center, and of course, the Chancellor's Office. So the mission of the LEAD Center, you're reading it here, is to conduct high-quality research to understand environmental, lifestyle, biological, and genetic determinants of obesity and diabetes and associated conditions, which are all throughout the life course. What's interesting, in my opinion, about the LEAD Center is its approach. First of all, it is anchored in longitudinal human cohorts that span the life course, which is a unique feature of the LEAD Center on this campus and across some other life course centers, though many life course centers that I'm familiar with do have such longitudinal human cohorts. And they are clinical and population. And what I mean by that is that some of them follow children or individuals with a disease, and others follow children, pregnant women, individuals that are healthy. Another aspect of the LEAD Center approach is that we've created a collaborative and multidisciplinary center that includes faculty who are epidemiologists, faculty from pediatrics, basic scientists, biostatisticians, environmental health researchers, radiology experts, genomics faculty across departments and schools. So it really isn't focused in a department. It isn't even focused in a school. It is across department and schools. We do train. A lot of the things that we do in the LEAD Center is with students, with postdocs, with research support staff, with junior faculty. And we also have an eye towards creating resources for the people in the center as well as for the larger community on campus and elsewhere. For example, core research services, study and data coordination, data management, data analysis. And ultimately, we are interested in the impact of our work and how to best translate our findings into preventive action. And actually, I think we can do better here. So this is not the most important aspect of the LEAD Center, but I want to highlight. Oh, I was thinking of the next slide. This is an important aspect of the LEAD Center. I want to highlight some of the longitudinal cohorts that we work with. I mentioned some of them, the Healthy Start study, the SURGE study, the EPOC study. Within these large longitudinal cohorts, we've nested mechanistic studies, for example, multi-omics, mesenchymal stem cell types of studies using placentas that have generated grants, R01s, for our basic science colleagues. With these cohorts, we participate in national and international consortia, such as the ECHO Consortium, Environmental Influences on Child Health Outcomes, the PACE Consortium, some of these things informed the development of a new consortium, Discovery of Type 2 Diabetes Predictors in high-risk populations. We also conduct population-based surveillance of pediatric and adult diabetes. SEARCH was only doing pediatric diabetes. Its successor, DeKaya, is doing both pediatric and young adult diabetes. And we also do clinical trials focusing on obesity and diabetes prevention, the Diabetes Prevention Program. And this DPP inspired other clinical trials that are translating clinical trials into effective community prevention programs, Tribal Turning Point, or trials during pregnancy to break the intergenerational cycle of obesity and diabetes in RICH. And so the LEAD Center currently has 60 members, 11 tenure track or research track faculty, 9 research associates or instructors, 32 research staff, 8 trainees, and we have trained collectively 7 doctoral students, 10 postdocs, 12 junior faculty who have obtained their own grants, including R01s. This was the one that I said may not be that important, but I'd like to show this too. It's important to look at grant revenue occasionally, not in addition to looking at impact of your work. So since inception, since 2015, see Lori smiling there, we submitted 164 proposals, 90% of them to federal funders or federal sponsors. 53 projects were funded for a funding rate of 32%, which is way much better than the 7th percentile that I'm hearing now, being the pay line from many institutes. And funded projects a total over $44 million and generated over $14 million in indirect funds. And the figure here shows how we grew over time. And currently this year, we have 29 active, mostly NIH 2 CDC grants, $10 million annual directs, $3.2 million indirect costs. The important things on this slide are the next two bullets. Grants belong to 9 core faculty with appointments in the School of Public Health and in pediatrics. It started with 1. Now we have 9 for bringing this revenue and having this impact. And also an important bullet. These grants provide partial or full support to 11 faculty, full support to 3 research associates, and 46 research staff, fellows, and students. So in addition to the impact of our work, we hire, we provide training, we provide work to people here in the state. I want to go really quickly and highlight some of the large studies that we're doing in the LEAD Center. Not all of them, don't worry. I'm highlighting here the Healthy Start study, which is a pre-birth cohort of 1,400 pregnant women who were recruited from University of Colorado Hospital clinics since 2009. So this study is going to turn 15 next year. We're going to celebrate. So these participants were followed from the first trimester of pregnancy through delivery into childhood, and are currently followed as they are transitioning through another developmentally sensitive period, puberty, 10 to 15 years. Initially, the exposures of interest, the factors we were interested in were maternal and early life environment, weight gain during pregnancy, diet, physical activity, substance use, environmental chemical exposures, but also depression, stress, social determinants during pregnancy and early life. And we had a specific interest in mechanisms, which is why we collected placentas, mesenchymal stem cells, and samples to, in the future, do epigenetics and metabolomics. And this has paid off. It has built careers for people in basic science who are using our samples and our data. In terms of outcomes, originally the interest was offspring growth, adiposity, cardiometabolic markers, but we branched into many different directions: infant and child behaviors, feeding practices, brain and neurocognitive development. We have longitudinal brain MRIs in the study. Lung development, respiratory outcomes, allergic diseases. We have a faculty member in pediatrics who's putting in a large RCT based on preliminary data from our study, from our cohort. Glucose and insulin homeostasis during puberty, which is the period when, if it develops, type 2 diabetes in youth develops. So this led to a new R01, which we call Healthy Start 4. And then maternal and cardiovascular and chronic disease outcomes, because we got a grant to follow the moms of these kids in what we call Healthy Start Moms study. Last but not least, this cohort is part of this national consortium called ECHO, which is a consortium of I don't remember the number now, but 60 or so similar cohorts throughout the United States that joined forces to do more and better and work together. We were part in cycle 1, and we were part of this consortium in cycle 2, which means we might have done a good job. This cohort has been continuously funded. It has generated, as I said, numerous ancillary grants, collaborative projects, including with partners from Colorado State. They're part of ECHO with an environmental sciences focus, CU Boulder Nexus, DU even, we are exchanging trainees with DU, basic science colleagues, national and international consortia. It has contributed to career development. 4 K99s R00 nested in the study, doctoral grants, capstone projects. I want to quickly mention the Search for Diabetes in Youth study. This is the study that motivated me to come to Colorado. I came to Colorado to be part of this study. This is why I chose Colorado over some other offers that I had at the time. Search started in 2000 and ended in 2020, and it was a 2-in-1 study. It's a multi-center study, but it had a registry component that did surveillance of pediatric diabetes across 5 US centers listed here. It identified all youth with diabetes diagnosed at age less than 20 years in a population of about 5 million at risk. And so this component defined a burden of diabetes in youth in the United States by type of diabetes, by race, ethnicity. It provided trends in burden and risk and projections for what's going to happen in the future. The second part of the study was a nested cohort in this registry that was prospectively followed for up to 20 years. Youth with newly diagnosed diabetes that were followed to understand risk factors for complications, transition to adult care, quality of life, mortality. And remember, we studied type 2 diabetes in youth as well, which is still a novel pediatric condition. It is the only study in the United States that did so for such a long time with both type 1 and type 2 diabetes. I served as co-chair of the steering committee for the study for 15 years, and this has also generated many ancillary studies listed here, some which I led, some which my colleagues led, including a Search India collaboration where they wanted to learn from us how to develop a registry. They wanted to harmonize their registry with ours, and we published some interesting papers. However, since we did so much, the funders decided that it was time to end it. And the successor of Search is DCAIA, which stands for Diabetes in Children and Young Adults, funded solely by CDC, which conducts EHR-based surveillance in youth and young adults. So without any in-person visit, just EHR-based surveillance. I think we're a little far from doing that perfectly, but we are trying. And then we've submitted 2 new large R01s in November. One of them focuses on disparities in cardiovascular outcomes in participants with type 1 diabetes, and we got a 10th percentile, so it might be funded. We'll see. And then diabetes prevention program outcome study, which is a study that I didn't start. Dr. Hammond started here in Colorado, but it's also a multi-center study. It actually includes 27 sites in the United States. It started as a randomized clinical trial of over 3,000 overweight adults with impaired glucose tolerance. And there were 2 interventions, a lifestyle intervention and metformin intervention versus placebo group. And then they were followed in the active portion of the trial for 3 years and then up to 25 years in the outcomes observational study. And in this study, diabetes risk was reduced by 31% by metformin, by 58% by lifestyle. And these risk reductions were sustained somewhat reduced, but sustained over 15 years of follow-up. And heart disease and stroke risk factors were also reduced with fewer medications in those in the intervention groups. In the third phase of the study, which I became the PI for, we followed the cohort for cancer, for cardiovascular disease, for diabetes complications, and now via a U19 funded by NIA, we are following them for Alzheimer's and related dementias. This is another study that has impacted the field enormously. And just a picture of the lead center, faculty, research staff, trainees here during the retreat we held last year. Just a way of saying thank you to all of them. I also want to mention a little bit about one-on-one mentoring, because I think that part of the reason that I've accomplished what I've accomplished is due to the mentors I had, and also to what I've provided to others during one-on-one mentoring. And I'm just going to talk about what I did. I mentored 10 PhDs, 8 of them women, 4 dissertation committee chair, all of them women, 3 MS in Epi chair, all of them women, 8 SPH thesis chair, all of them women, 7 of them women, and 17 junior faculty or postdoctoral mentees, 15 of them women. I can't stress enough how important one-on-one mentoring is for a faculty member, for a center director, for a department chair, for an associate dean for research. And a little bit of my approach to mentoring, it's not over when they graduate. So it's a life course. It's a life course approach to mentoring as you evolve, as they evolve. I'm thinking the important things are to offer sustained support over years of training and early career decisions, and not stop when they graduate. To me, one of the most important things is that you and the mentee, the pair, works towards common goals. And there's always a two-way street. What the mentee learns from the mentor, what the mentor learns from the mentee. Guardian angel, create optimal environment for growth. Role model, especially if you're mentoring women. And the personal collection, assist with work-life balance. As careers mature, provide opportunities for research advancement and career growth, review papers together, discuss grant proposals. I read numerous grants of my mentees, provide access to infrastructure, cohorts, research support, network of collaborators. Then, as careers mature, include them in grant leadership positions. For example, program director. There's nothing shameful about having a mentee take a program director position. This is how I started, and I've learned a lot. Subparts of a larger grant, transition to become a PI or an MPI as the career matures. And encourage activities that bring visibility and experience. For example, member of study sections, chair of a working group in a large collaborative study. And then peer mentoring at any level. Peer mentoring as a junior faculty, peer mentoring as a senior faculty. It is so important to have a peer that serves as a sounding board. I was blessed to have that in my career, and I think it's totally crucial. Plan studies that can be done together, co-chair multi-center studies, and learn together. Okay, now, why this position and why now? I am actually genuinely interested in this position. Because of these reasons, I am looking forward to enhance the school's research portfolio in terms of infrastructure, in terms of visibility, in terms of revenue, and definitely in terms of impact. I am excited by the opportunity to contribute and to give back to this community that has helped me so much and has helped me achieve what I've achieved in over 20 years of being here. You know, as with mentoring, I thrive and I enjoy and I come to work because I like to help others reach their full potential. So I do think that this motivates my desire to apply for this position as well. And of course, impact population health through research. And why now? Well, we have a new dean. I'd like to work with a new dean. I perceive the environment as being progressive, entrepreneurial, and growing. I mean, I'm not sure. I mean, I think that's correct, but this is a motivation for me. And also, given the stage in my career, there's a desire to challenge myself in a somewhat different way. Not completely different. So a little bit about my vision. I'd like to promote in this role, I'd like to promote, or even in the role of a director of a center, promote transformational research through advancing collaboration. I think that's what I've done with the LEAD Center, and I think that's something that our school needs. And I'm giving this as an example, but it's an example. It's not the only way we could do this. I think of life core research as such a theme. It's a novel, integrative theme. It's a unifying theme. It's not specific to any disease, not just diabetes, cancer, cardiovascular. It's not specific to any investigator. And as you saw in my prior slide, it should focus on health, which is what a school of public health should do, promote health. And it should work across the translational spectrum, from basic science to program implementation. Now, for such a theme, we're fortunate to have this campus with pediatric and adult care services on campus. And if they were better aligned, this would allow long-term follow-up of actual or virtual cohorts. So I think we could benefit from this structure that we have here. And then certainly transdisciplinary teams linked through enhanced research structure and capacity is the way to do this. This is just an example. It doesn't mean that this is the thing we do or the only thing we do. A little bit about strategy. I think the ADR for the School of Public Health could focus on issues that will improve the health of Colorado. First of all, we need to know what those issues are. And I think we have data. Substance abuse and opioid epidemic, mental health issues, chronic diseases that all are the consequence of obesity, more or less. Health effects of climate change, and others. But start there. Start with what matters for the health of our state, our communities here. Potential approaches. I continue to think that one of the most important approach could be to leverage school and campus strengths that are aligned with national priorities. This would be a way to prioritize our research, our work. And just as an example of what I think some of the national priorities are and campus strengths or school strengths that can be better aligned might be. Of course, there are others. I perceive a need for large collaborative projects, data sources, consortia. And we have ECHO, we have SEARCH, COPD Gene, TEDdy, and many others. We have some strengths already. What we could do more of is leverage shared resources to align better with such national priorities. For example, develop, support, maintain human cohorts. Develop further data warehouses. We have the health data compass. We could do better. We could do more. We could link with warehouses outside of hospitals on this campus. Another example of national priorities, multidisciplinary and team science. And we have examples here. We have the LEAD Center, which is multidisciplinary. We have Piper, which is across schools. We have the Center for Health, Work, and Environment, which collaborates with CSU, which collaborates with Boulder. We have the Center for Global Health, which is also across schools. What we could do more of is support such multidisciplinary centers and foster additional partnerships. Another priority is solution-oriented research. Research that provides practical solutions to real-world problems. We hear about this every day in ECHO. Solution-oriented research, how do we make it solution-oriented? Well, first, we need to know what the problems are, but think about doing the research, implementing the programs, and informing the policies. So I think we can do more here and link centers here that do fragments of this continuum in a more cohesive way. And precision medicine, another example, we have the CCPM, we have clinical informatics, we have the Department of Biostatistics and Informatics, we have CETA. Clinical medicine, precision medicine might be already taken, but we have precision prevention to focus more on. Data science, omics. Just some examples. There are other national priorities where our school has strengths, and we can certainly talk more about it. A little bit more about leveraging collaborative strengths. I think it would be important for us to develop, maintain, strengthen partnerships with campus hospitals. UC Health, Children's, VA is now here, and other hospitals in Colorado. Not only because they could have participants for our studies, but they are also places where our research can be disseminated and programs can be implemented. I think we should strengthen our partnerships with other schools on campus, chiefly the School of Medicine, but all the other schools as well. More partnerships with our partner institution in research, not just in teaching. At CSU has so many strengths that complement ours. The environmental sciences groups there, UNC as well. And then strengthen partnerships with state and local health department, again, for surveillance, for example, program implementation, program evaluation. I think we also need to leverage shared resources in the school to create them and then leverage them. As an example, just because that's what I'm familiar with, human longitudinal cohorts, data and sample repositories, because they create the population research infrastructure for our studies. I think we should develop cores. And again, an example that I give, but there are many others. Develop capacity to serve as coordinating center for large multi-center studies that deal with a lot of data, and studies that deal with data collection from participants, from actual participants. A nutritional epidemiology core, and many, many other potential examples here. And increase links with our communities. Communities in Colorado that participate in our studies. For example, we now work with Denver Health, and they have a community advisory board and a community that they serve. We have links with indigenous tribal communities. We work a lot with the Navajo Nation, for example, and have worked with that nation for 20 years. We have to increase the links and not only get from them, but also give back. Other potential approaches. I'm going to say this, support a researcher. I'm not going to say how. Maybe I will a little bit. Support a researcher, the faculty, the research associate, the PRA, the research support staff. Some ideas, there are many others. I'm thinking we might want to identify, support, and retain research champions before they leave, so that they don't leave. I think we should promote our faculty more as local and national ambassadors, locally in the various leadership positions on this campus, and nationally, National Academies of Sciences and Medicine and Sciences. Why not? In addition to nominating them for awards and all the other things that we do. If we want to hire with this collaborative mindset, identify, support, recruit faculty in research clusters. So some go to one department, others go to a center, they come with trainees to build that research theme that we're interested in building. Support raising stars by providing them matching funds, for example, and things like that. Support undergraduate and graduate students and postdoctoral fellow engagement in research by hiring them as PRAs, as research associate, by helping them get grants, by thinking of diversity supplements. Boost school and institutional support, and the support can take many forms. Financial support, for example, support development of large grants, think of matching funds, incentives. And I'm not saying more about this now, but yes. Mentoring. The one-on-one mentoring is important. I don't think we can replace that. But also structured mentoring, grant writing, seminars, webinars, workshops, mini study section reviews for grants at any level, junior, senior faculty. And support in terms of infrastructure, access, but especially efficiency. And I'm going to say this, not a lot of detail now, I can discuss this more. Rethink, perhaps improve or rethink our current model of research support, promotion, and tenure. It's too much to discuss for now. Other potential approaches: improve research infrastructure and especially increase efficiency. And I'm going to give you some examples of things that we're doing in the LEAD Center under the leadership of Sarah Trimmer and Lisa Testaverde. Thank you. They've created a learning and research hub in this area of knowledge management with 5 areas: general operations, pre-post award, procurement, research implementation. So that documents everything that we do clearly, shortly, efficiently, accessible, transparent. In terms of process improvement, they are working on automations. I said that. I have trouble with this word. So automated pre-award process with standardized checklist. This reduces enormously the time that faculty, that research grant administrators put into submitting a grant. Automations for tracking submissions and funding statistics. Kathy has already started this in her tenure as ADR for the school. We're improving the onboarding process with a smart sheet checklist for new employees. I've seen this already done at the school level, but it started with Sarah's ideas. And implement a funding management system. I think Sarah is working on her software to better do this in an automated way. And then training. Grants 101 for new hires. We do that orientation to the LEAD Center portfolio, overview of CU-wide grant services, grant-related considerations for procurement for travel cards, what's allowed to charge directly to sponsor project, fiscal best practices for research managers. I want to say that in the LEAD Center, we have about 1.6 FTE dedicated to grant administration processes, but all our project managers are trained in developing a budget, tracking a budget, submitting a budget if necessary. So it's really not just either on faculty or on one person who is the grant administrator. So some things that the school can perhaps do as well. And then, in general, as a potential approach, identify barriers, find solutions. Just some examples, some barriers. We have units in the school with distinct priorities, and this might lead to friction. And this is not unique to our school. They exist in all the schools, and there are schools with different priorities on this campus. There's limited communication regarding various enterprises underway, little unclear accountability in terms of developing, funding, implementing cross-entity initiatives, and perhaps the most annoying part, complex research funding flow within and across units, limited ICR, which limits collaboration. So potential solutions, we might want to think about a school-supported system that integrates research being conducted in similar areas in various units and various schools. Identify collaborative opportunities, connecting researchers, disciplines, and campuses. More efficient pre-post award support, grant tracking system, submission and funding statistics, revenue tracking. We have to increase connectedness of data resources so we can document faculty, fellows, grants, and manuscripts, maybe interfolio will get us there. We need to lower financial barriers between entities and decrease complexities. But now, if you have to split a small amount, there's always going to be friction and problems. So best would be to increase ICR and then improve it. And I'm going to end with this slide. Why me? I like to think of myself as being an inspirational leader, and that's what I would like to be. I think I bring skills to this role that have to do with research leadership in areas of science, administration, management, strategic planning and critical thinking, trust and credibility and reputation, and communication. My communication style is direct, clear, and transparent. That may not work for everybody. This is who I am. And I also bring knowledge, university culture. I've been with this campus for 23 years. I have some knowledge of national research priorities and campus strengths, probably not all the knowledge in the work, and on developing research themes and programs. And in this role, whoever is in this role, I think the person should work with centers and departments, should work with the research committee, should work with the other associate deans, because a lot of the things that I talked about relate to other areas of the school, and certainly should work with the dean. And it would be especially important now that we have a strategic plan underway to make sure that we integrate more than split and try to accomplish our vision and goals. So thank you very much. As always, I don't leave too much time for questions.
Thank you, Dana. I open the floor to questions.